We will discuss coronal polish in chapter 32, which starts on page 754 of your dental assisting textbook. In this chapter, we will define coronal polish. We'll describe and explain the rationale for each step in the coronal polish procedure. We'll explain the indications as well as the contraindications for coronal polish. We'll describe and identify the dental deposits and stains. We'll list and explain the types of equipment and materials used to perform a coronal polish, and we'll list the auxiliary polishing aids and explain their functions. Coronal polish is part of an oral prophylaxis, and an oral prophylaxis includes the removal of hard deposits. With a coronal polish, teeth are polished using a rubber cup, which is the removal of soft deposits and extrinsic stains. So with that, we will need a rubber prophy cup, a prophy brush, and an abrasive. The rationale for coronal polish, or why we even do a coronal polish, is number one, it makes it easier to keep the teeth clean. This is because a smoother surface keeps or prevents materials such as bacteria, plaque, or foods from sticking to the tooth. Also, it'll motivate a patient to maintain their oral health because when they leave the dental office and they have nice shiny teeth, they're more likely to continue their home care or their home hygiene care. It'll slow the accumulation of new deposits, again, because the tooth remains smooth. It absorbs fluoride better, and it helps prepare a tooth for other procedures, such as the placement of enamel sealants and for orthodontic bracket and band placement. There are some conditions that a patient may present that discourage the use of coronal polish. For some patients, the polish may be modified to accommodate a specific condition. The dental assistant should recognize and consult the dentist upon detection of any of these conditions. And this will include some orthodontic appliances, teeth that may be hypersensitive, patients that have green chromogenic bacterial stain, and minor oral irritations. They have toothache, or if they have some type of lesion that will make it painful to do a coronal polish, it might be a contraindication or reason why you shouldn't polish that particular area. Soft deposits include acquired dental pellicle, materia alba, which is a heavy accumulation of plaque, food debris, and then regular plaque. These can be removed with the coronal polish. Calculus is a hard calcified deposit that forms on the teeth. It can appear both supragingivally, which is above the gum line, and subgingivally, which is below the gum line. The dental assistant should be able to recognize both. Also, the dental assistant is not legally allowed to remove calculus. Stains are discolorations of the teeth that can be originated intrinsically, which means inside the tooth structure, or extrinsically, which means outside the tooth structure. Intrinsic stains include dental fluorosis, which is the result of high concentrations of fluoride received systematically during tooth development. Pulp damaged or non-vital tooth stain is when the pulp is damaged or removed. A tetracycline stain is when you have high concentrations of tetracycline as antibiotics taken when the tooth was developing. And metallic stains result from inhaling salts in industrial settings, certain drugs, or materials used to restore teeth, such as amalgam fillings. Extrinsic stains include yellow and brown stains, which result from poor oral hygiene, tobacco stains, which result from coal tar in cigarettes and chewing tobacco, green stains, which result from bacteria found most frequently in children, black line stains, which is mainly found in women when there is excellent oral hygiene. Orange stains result from bacteria related to drug therapy, such as antibiotics. And chlorhexidine stains, which result from long-term use of chlorhexidine, which is found in some chewing gums and the medicated mouth rinses that oftentimes hygienists use. Abrasives must be selected carefully. They should not be so rough on the tooth and tissues of the mouth as to cause damage or deterioration of the tissues. Sometimes there are powders or pastes which are used to remove soft deposits, and there are different varieties that have different grits depending on what you need to polish. Some equipment and supplies that you will need is a handpiece, usually a slow speed handpiece for cornea polishing, some type of abrasive, which can consist of prophy paste or some type of pumice powder that is mixed with water. You will also need a rubber prophy cup, sometimes a prophy brush, especially when dealing with certain orthodontic appliances. And you may need dental tape or floss. The tongue may need to be retracted and moved throughout this procedure. A mirror should be used for better vision. You will have to adapt the rubber cup to the tooth surface. Abrasives cut or grind, leaving the surfaces with grooves, and you can also leave the surface rough. So polishing, if done correctly, produces a smooth, glossy surface. It is important to follow a set protocol and guidelines when providing a corneal polish. The oral cavity should be kept free of saliva and debris, and the patient should be kept comfortable. The dental assistant should maintain proper body mechanics. The light source is critical to providing a good operating field. So you want to make sure that you have your operating light correctly positioned above the patient, depending on which arch you are working on. Some auxiliary polishing aids include bridge threaders, abrasive polishing strips, softwood points, and interproximal brushes. There are a variety of devices that may be needed during a corneal polish. The dental assistant should be comfortable in recognizing the needs for these abrasive devices and their proper use. These may be needed as a result of prosthesis when removing difficult stains, to get into pits and grooves, and to get between hard to reach areas. This is it for chapter 32. Please let me know if you have any questions. Thanks for listening.